stop cheering. I've got to get my own back at you after saying I couldn't show.
Well, we were taught.
Croeso I cyfarfod cyffredinol rhywun no. Diolch and ymuno. Welcome to our annual general meeting. As you know, we will be reporting on our performance during the last financial year and other achievements. And we're really pleased to see so many people have wished to join us today. And we have people in person as well, so welcome. Today's meeting is being live streamed, as you know, as well as being held in person. And thank you very much to everybody who's joined us, including our staff. The recording of the meeting will be available after on YouTube for anybody wishing to view it at a later time. 2022-23 was another very challenging year. Our staff levels of significant pressure and increased demands. There does, however, continue to be exceptional collaboration, determination and ambition seen across all teams to provide the best quality, accessible care that's available, for which we're really, really grateful to all of you as our staff. We hope you will see in our annual plan the exceptional achievements of individuals and services to ensure the ongoing delivery of healthcare throughout the year, despite the many challenges we continue to face. In a short while, we will welcome questions from the people who have joined us. A number of you have already submitted your questions, which has been very useful, and we'll go through those one by one. However, you can continue to submit your questions as we go through this meeting using the Q&A tool on Teams. We will respond to as many as we can, and for those that we cannot get to today, we'll ensure we provide a written response to you. And to all questions over the next few days. I'd like to introduce Nicola Prigodic, the Chief Executive, and she is going to proudly present the highlights of our performance during the last year.
Diolch and gwrando everyone, and it's a real privilege to share with you at this AGM the overview of the Health Board's performance. As briefly mentioned, it was a very busy year for the Health Board with some significant challenges and an improvement agenda that we've been working on. Demand continues to rise, particularly in our urgent and emergency care services, across cancer services, mental health services, and many more. And alongside that, workforce pressures in many areas continue to need and rely on a temporary workforce. And the financial context is probably the toughest yet, but we continue to keep quality and safety and experience at the heart of everything that we do and what we need to improve. So I just wanted to share a few achievements in that context of the challenges that we are facing. We very much set out a key mission in our IMTP last year, which is about trying to address the inequalities and improve population health, and very much keep a focus on that prevention agenda. And we were really successful working with our partners across Gwent to establish ourselves as a marmot leader, along with local authority partners, as I said, and we really are looking forward to launching that more substantively in the coming months to really confirm our commitment to tackling the health inequalities that we see across the different parts of the Gwent area. We all know coming out of the pandemic that the people were wanting to have more face-to-face GP consultations. Whilst there was great benefit in virtual working, and it still is, we have increased our face-to-face GP consultation rates up to 58% by April this year, compared to 25% in June 2021. And 46% of GP practices now using digital systems, and we continue to work with our primary care practices to look at how we can continue to improve access and the use of digital systems. Dental services, we've seen over 30,000 new patients. We know there's often a range of challenges in some areas more than others around access to dental services, and we've been particularly targeting that. We've got huge backlogs of patients waiting for diagnostic tests, outpatient appointments and operations. And we've got we had some numbers of people waiting more than 2 years and even 3 years for treatments, and we've put a real concerted effort to reduce the number of people who have been waiting those longer periods of time, and pretty much clear those in most specialties, apart from a small handful of specialties where we really are struggling to have the capacity to clear them as quickly as we'd like to. We've seen improvements in our cancer performance. Despite increasing referrals, we are now treating more patients than we've ever treated before for cancer, and we are trying to meet that cancer target where 75% of people will be seen and treated in 62 days, but we are on an improvement trajectory around that. We introduced the 111 Press 2 service, which offers urgent mental health support and advice to our patients and communities 24 hours a day, really supporting the most vulnerable. And I think it's a really good point of contact to help guide people through what is available for them on mental health services. So really good to see that implemented. And we signed off a people plan for 2022 to 25, which breaks down our plans into focusing on staff health and wellbeing, workforce sustainability, and being the employer of choice, really looking at how we support staff and make them proud to work for the Health Board. We've had a refreshed and relentless focus on quality and safety to really make sure we get it further improvements in the quality of care and improved outcomes for patients, and also looking at experience as well and how people things like communication, complaint handling as well. So we've recently in this year now developed a new quality strategy and patient experience strategy, and they really are quite key documents with the new duty of quality and duty of candour that have come into legislation since April. But really good progress around those areas. And we've had a significant focus on urgent and emergency care. We know this is where significant pressure, we still see an increased demand presenting to our emergency departments, minor injury units, and not just the numbers, but the acuity of patients that presents through there, and the whole, the impact of having lots of people in our beds, numbers of people in our beds who need to go home, but the challenges that we face in terms of workforce with local authorities as well, and working in partnership with them around delayed transfers of care, and that puts pressure on the whole system. But we've introduced new models around ambulatory care services. So we've got a same-day emergency care unit at the Grange, and we've got some other models in place, and really trying to look at how we can fast-track some of our patients through these ambulatory care units or bring them back the next day for further tests rather than making them wait for hours in a busy emergency department. We've continued to progress a number of strategic capital developments, so the work is progressing really well at Neville Hall on the satellite radiotherapy unit, and the endoscopy unit at the Royal Gwent Hospital is due to be finished very soon in the next few months, and the breast unit at Ysbyty Ystrad Fawr is also due to be completed at the end of this calendar year for opening in 2024. So really good progress at each of our enhanced local general hospitals. We've really progressed some good work with our partner health boards in terms of Cwmtaf, Morgannwg and Cardiff, working together on a number of areas where we think we can make greater progress together, particularly around areas such as ophthalmology and addressing some of those backlog of patients by working together. So there's just a few kind of headlines from the whole amount of work that there's going on across the Health Board. In terms of our IMTP, our Integrated Medium-Term Plan last year, we tried to set out what we were planning to do across 5 priority areas, looking at this through a life course approach. So looking at the age of our population from the children, giving them the best start in life, right the way through to respecting people and making sure that when they die in well as part of the end of life, and the whole kind of life course from that early start to the end of life. So what I was going to share with you is some of the metrics that we've been trying to capture across this life course approach to demonstrate what progress we're making and what areas we need to do further work. This is still in kind of work in progress because not all of these have got the outcomes that we would like, or they're not captured in detail sufficiently. But it is starting to take a lot more progress, and it does give you a slightly different way of looking at things rather than some of our traditional metrics. So the first one, priority one, which is giving every child the best start in life. Some of our key commitments in this area was around improving good health in pregnancy, optimising a child's long-term potential, and increasing childhood immunisations. We continue to do quite well around our childhood immunisations, with some areas that need some further intervention and targeting. We've seen some good progress around the good health in pregnancy with smoking rates, decrease in stillbirths and low birth rates, but more work to be done in terms of some of our 8-week checks and obviously our contact with preschool. So further work around our kind of preschool and our health visiting services to improve those areas, which we've been looking as a priority as we go into this year. Also continue to really try to promote breastfeeding in women. Currently at 6.6%, but an area where we're really keen to increase that, given the evidence that we see for babies when they've been breastfed. Okay, priority 2, which is getting it right for children and young adults. The commitments in this area was around improving mental health resilience, support being a healthy weight, and improving healthy lifestyle behaviours. I think it's fair to say we've seen significant increases in demand around mental health and children accessing services, and we continue to try to look at innovative ways to respond to those working with schools and other partners. But we have seen some deterioration in the compliance with our neurodevelopmental waiting list, and some of that is because of the increased demand. And we've done some work now where we separated out the pathway for children that are 0 to 5 and those that are over 5 to really try and help make some progress around this. And then we've got very much similar statistics around healthy lifestyles, and healthy weight is showing that it is a slight improvement, albeit we know obesity in children is a key priority that we are working with partners on. We've also, which isn't captured in that particular table, but as part of our recovery of waiting lists, you know, people who are waiting on surgical lists, etc., we've really tried to prioritise children who are waiting a long time, because 2 years in a child's life is much more significant than 2 years in somebody who's in the older part, to be able to ages, middle ages, call it what you want, but for adulthood. So we really have tried to consider the long-term impacts of delays for children and try to prioritise that in our work. Priority 3, which was around adults living healthy and ageing well. There probably could be 100 different metrics in this particular category, because this is where most of our interventions take place in some of the hospitals. But one of our commitments is about maximising individuals' time and trying to not make people wait longer than they need to for their care. This is one of the most challenging areas, because despite us increasing the amount of people that we see in since as we kind of come out of COVID, the amount of referrals we get in and the backlog, and trying to get us back up to those levels before the pandemic has been challenging. So we've seen a slight increase in the number of patients waiting more than 36 weeks for treatment, and an increase in those waiting for a follow-up appointment. They weren't measures that we set out early on, but we are seeing improvements in our 104-week waits and 156-week waits, as I mentioned, with a commitment to try to clear 156-week waits by September, October this year. So should see some big improvements in those during this financial year. We have increased our urgent primary care contacts. We've now got urgent primary care across the health board, which really does offer alternatives for people to access an ED, or if there's issues around GP access. So that's a really positive progress. And again, we've seen that kind of increase in 111 calls, and seeing more, less people inappropriately attending some of our emergency departments. Progress. The measures around ambulance handovers, waits in our emergency department, and the waits to be seen by a clinician have all deteriorated from March to March or April to April. We have seen improvements in some of those since March because we've put in particular efforts around the emergency department at the Grange and our ambulance handover focus, which we introduced a new system in May, and we have seen the benefits of that in the first kind of 6 months of this financial year, albeit, you know, it continues to be a huge challenge for us and is linked to the patient flow across the system. But we do appreciate this is an area where we get a lot of feedback from the public around waits in our emergency department, and we are continuing to progress a case with Welsh Government around an extension to the emergency department at the Grange, recognising that at times where it is hugely congested and not a good patient experience. Priority 4 is where we are looking at all the areas to make sure older adults are supported to live well and independently. We recognise when people are older, how do we make sure we keep them at home where possible, and if they do need to come into hospital, we get them back home living independently as quickly as possible. So we have seen improvements in some of the work we've been doing around admission avoidance, which is about reducing admissions and time spent in hospital. Decreasing the number of patients whose length of stay is over 21 days. So we have seen an improvement in that. But we know this is still a huge area of challenge for us. Some of our metrics showing that we kind of hold in our position, but not improving them when we need to. So this continues to be a key priority, trying to deliver care closer to home as possible, and really trying to prevent people needing to come into hospital in the first place. And this is work that we are doing with our local authority partners so that we can look at the alternatives, because we know the evidence shows if you spend long times in hospital, it is deconditioning, there's risks of falls, risks of infection, and therefore it's not a good place to be if people can live safely at their own their home or care homes and so on, with their family. And the final priority area was dying well as part of life. I think we are really keen to ensure that we offer compassionate and dignified care when people are faced with end of life, and we really try to make sure we improve our planning and provision of end of life care and really respect people's wishes when it comes to their end of life. So these are a number of areas. The metrics are not quite as kind of advanced as some of our others, but we have identified areas where we think are important metrics to look at people's end of life experience, which is increasing the amount of people who don't want to die in hospital, making sure we certify deaths within 5 days. That's improved because there are sometimes examples where people have waited longer than you'd expect for death certification, which causes huge distress for families. So we've seen an improvement there. We're really focusing on complaints. We have seen some improvements in our complaint response times, and we're trying to get our metrics more transparent around that in this report. And we've seen an increase in the proportion of patients referred to urgent palliative care within 2 days. Again, making sure they are referred to people with the right skills and expertise in managing this. A really important part of our business that we are keen to support. And then whilst we try to look at how we making progress across the life course, we manage much of this work through priority programmes of work. And there were 10 priority programmes set out for 22-23. I've covered lots of this work, but very much this is how we make sure we've got an improvement plan, we know where we need to get better, we know what's not going so well, and how are we going to do things differently. The ones I haven't probably spent as much time on, so public health protection and population health. This very much has been focused on the COVID response over the last few years and continues to look at how we can support people with a vaccination programme and make sure we've got a really good response to any health protection issues which emerge in the population. And this whole agenda around working with partners as well and the public about the health of the population and looking after themselves, smoking, obesity, healthy lifestyles, all of those that really, because we know there is so many deaths that are avoidable through cancers and other things through health issues. The accelerated cluster development, that's the work we've been doing with primary care and GPs, looking at how GPs can work with other practices in their area, which we call clusters, and really looking at the offer beyond just the GP themselves, offering mental health practitioners, physiotherapists, paramedics, and really trying to have a more holistic approach to meeting people's needs. Some of that's about counselling support, because we know things like loneliness are a huge issue for us. So the accelerated cluster development is trying to look at things on a wider scale than just than one GP practice, which has got proven benefits. Redesign and services for older people I've covered to a certain extent, but this is really looking at how we keep people out of hospital where appropriate. I've talked a lot about urgent and emergency care. Planned care recovery is where we look at our waiting lists. We're doing pretty well on our diagnostic waiting list, so we've got one of the lowest waits. People should be seen within 8 weeks for a diagnostic test. I think we've got the lowest numbers of people waiting more than 8 weeks in Wales, and continuing to make good progress around cardiology, radiology and endoscopy, which we hope will improve further with our new unit. Maximising cancer outcomes. I talked about cancer briefly. Huge referrals increases in some areas, but continuing to work hard to make sure we get people treated as quickly as possible, recognising, you know, the challenges of people who are living with cancer and the need for quick treatment. Mental health services, we've got a transformation programme really looking at how we particularly transform mental health services, the 111 I mentioned, but what we can do in terms of the prevention agenda, access to primary care mental health quickly. And then we've also been developing a plan which is to have a new specialist mental health unit in the future, and we completed an outline business case for that this year and are in discussion with Welsh Government about taking that to the next stage. We continue to look at the Royal Gwent, Neville Hall and Ysbyty Ystrad Fawr in terms of their role as enhanced local general hospitals in the Grange, and making sure we've got the right services there with the right workforce to serve those local populations. Decarbonisation is a really important agenda because it's really important that we work towards the Welsh Government targets of being carbon neutral. And there's been a huge energy across the organisation. Many of our staff are very committed to looking at the decarbonisation agenda, which is not just about energy, but it looks at consumables, looks at procurement. So really important agenda we're working on there. And the final one is around agile working, really trying to be more smarter about the way we work, look at what we've learned from the pandemic, and trying to reduce the footprint and the space that we're working in by being more agile and supporting people to do more working when appropriate as well. So that's how we the two ways we've tried to look at our outcomes through the life course approach, but driving these programmes through these priority areas. And as you can see, we've made some good progress, some areas further work to do, and this year's plan, really, which Hannah will come on to, really does set out how we try to take this now to the next level this year. So thank you very much.
Thank you, Nicola. That was, I think, a very helpful overview, which will be built on by Hannah in terms of what we're trying to achieve this year and beyond. If we can move to item 3, the presentation of the financial accounts, and Rob Holcombe, the Director of Finance.
Thanks, Anne. I'm going to cover 4 areas today as part of the financial review of last year. First of all, a review of the accounts position and audit assessment of that, our performance in terms of financial KPIs, how we use our resources, and then a quick brief of where we are with our charitable funds, which won't be subject to audit and the accounts publication until later in the year. Next slide, please. So in terms of the audit opinion or our accounts for the financial year, in terms of the view of whether they present a true and fair view of how we have accounted for our resources, clean audit opinion on that. We have an opinion then on the regularity. So have we spent our money aligned to the rules and financial arrangements we expected to deploy our resources in? And whilst we have been judged to have complied with the regularity around the use of our resources, we do have a qualified opinion on regularity as part of our statutory duties, because we have a statutory duty that requires us to achieve break-even over a rolling 3-year period. And in 22-23, it's the first time as a health board we reported a deficit of just over 36 million. As a result of that deficit, that's driven the qualification on regularity. Next slide, please. In terms of some of our performance information and position then, the tables there present the revenue and the capital resource limits. So revenue is funding that we receive for our daily operations, and capital is received for things like buildings and equipment that cost above £5,000. They're quite simple sort of explanations of how revenue and capital works. In terms of the revenue position, as I say, we have favourable positions in our rolling 3-year position up until last year, and the cumulative balance that we held for the last 3 years, unfortunately, on last year's overspend and deficit, that's thrown us into a rolling 3-year deficit position. In terms of capital resources, it's better news, and we continue to operate with very small underfunding, which is in line with our 3-year duty. Move to the next slide, please. In terms of other targets, we have a requirement to pay our suppliers 95% of our suppliers within 30 days, and we've achieved that. And we have a Welsh Government cash balance target, which is a guideline figure to be within £6 million at the end of the month and the end of the year for the cash we hold within our own accounts. Some key points to note around the changes in funding and costs last year. So we had reduced non-recurring funding of 110 million, which we've had previously for COVID and dealing with the pressures of COVID. There was a new technical accounting standard, IFRS 16, which reclassified certain lease costs from revenue to capital. That was cost neutral to us. And we utilised a significant provision for annual leave, which was implemented during COVID to allow staff to take leave and carry forward into a future year so we could manage the implications of COVID during the highest times of pressure. In terms of our expenditure profiles, so how do we use our funding? So we received £1.7 billion of funding during 22-23. In terms of how we've accounted for it through our core accounting categories, primary care services, which includes GPs, optometrists, dentists, and prescribed drugs, we spent £307 million on those services. In terms of our secondary care services, identified in the hospital and community services, we spent just over £1 billion. And other provisions, including the majority of which is specialised services, 474 million. In terms of the graphs below, what they present is for primary care, GMS, which is GPs in the community, and prescribed drugs increased the most. Hospital and community staffing increased the most. And in terms of other category, specialised services provided through Welsh Health Services Committee and the funding for ambulance services across Wales were our two greatest spends in the other category. Next slide, please. So what this slide outlines is basically how we have utilised our available resources for the benefit of the population and patients within our responsibility area, broadly the Gwent area. So just to draw out a few key statistics from that, there were over 2 million GP attendances last year, over 16 million prescriptions written, over 100,000 operations on patients, over 500,000 bed days used, and over 800,000 outpatient appointments. There are a few more stats on there for reference, but hopefully that provides a sense of the scale of what services are provided with the resources we've been given. Next slide, please. So in terms of, again, some key statistics coming out, our spend on pay for the year was 782 million. There's an overall increase in staff of 255 whole-time equivalents, and some other, if I can go to the next slide, please. And then in terms of some other factors, we saw, as everyone did, an increase in costs in our utilities bills during last year of £12 million, and an increase in prescribed drugs costs of 8 million. And they're reflective and part of what was driving our deficit for last year. Next slide, please. So how have we utilised our capital funding? So many schemes are identified in the table there. Some are work in progress, some are completed. So Tredegar Health and Wellbeing Centre, the endoscopy service redevelopment within the Gwent, finalising some of the Great University Hospital works. Obviously, that's been opened for a couple of years now, so that was just finishing off any residual requirements. Newport East Health and Wellbeing Centre, again, that's something that's work in progress at the moment. The breast centre at Ystwyth Valve and Neville Hall Satellite Radiotherapy Unit, which is again work in progress. And we've had some funding for the and deployed some national imaging programme developments around equipment. Next slide, please. So I'm going to move now into the charitable funds. As I say, these haven't been subject to audit yet, and that'll be towards the end of the year. And they'll be published a bit later once they've been. So ABUHB operates as the corporate trustee for the charity. The charity is for the benefit of the NHS and is considered for public benefit. Move to the next slide, please. What these graphics present are where we get our income from, and the left pie chart identifies significant funding comes from donations, which are kindly given to us through patients that have had good services from us, and other charitable fundraising events, either through staff or general public. That's the biggest part of our income for last year. We do have some investment income as well. In terms of how we've utilised that funding for charitable purposes during 22-23, the largest parts, as you see from the pie diagram, for staff education and welfare, that's 35%, and 39% on purchase of equipment. Next slide, please. And to just sort of give a feel for where we've deployed some of those resources, we've implemented funding for various therapies, seasonal activities and support groups, including the Friendly Me volunteer service and other education and welfare events for staff. Particularly training courses as well. There's been quite a lot of funding for staff training courses, conferences and seminars, and there's cost then in terms of running the charity that's been applied. Yep.
Thank you. We'll return to questions at the end of the session. I'd like to turn to Hannah Evans, the Director of Planning, Partnerships and Performance, who will give us an overview of the IMTP for 23-24.
Thank you. So I'd just like to spend some moments presenting the plan as approved by the board in March of this year, with an addendum that updated the plan that went to the board in May of this year. The approach to the development of this year's plan really built on the approach from previous years that Nicola outlined. So in terms of maintaining the focus on health inequalities and improving population health, we retained the mission to sort of help shape and guide the plan for this year. Important as well to recognise the financial context that Rob just started to explore, and I'll come on to later in terms of the challenges for this year. And we need to maintain that focus on the life course approach that Nicola outlined, to ensure that we're keeping that focus through a population health lens through a patient's and an individual's life. However, as we can see as we move forward, the ask and the focus for this year's plan took the life course approach to sort of the next level, refining those metrics and delivery ambitions that Nicola outlined. But the plan also spends a lot of focus on responding to the ministerial priorities. So these were newly introduced for this year's planning cycle. The Minister set out 6 priority areas as outlined on the right of the slide. And just to explore a bit of what this means for us as an organisation and what patients and populations can therefore expect. So planned care set out the expectations around how long patients will wait to access planned care. So that means how long for an outpatient appointment, a test, so a diagnostic test, or waiting for surgery. Cancer is around how long patients wait on an urgent suspected cancer pathway, and the expectations of implementation of some of the standards of care around the national optimised pathways. So making sure best practice is incorporated into local practice and the specifics around different sites. Urgent and emergency care really focused on the benefits of same-day emergency care. So bringing patients in who are in an urgent or emergency situation and mobilising the rapid assessment, the senior oversight, and the testing that enables quick decisions on terms of a patient's onward trajectory in terms of their pathway, and focusing on getting patients back home to their place of residence. Mental health really is focusing on the timeliness of assessment and intervention for both adults waiting for assessment or an intervention, as well as children, and also the 111 Press 2 rollout and expansion. And primary care really set out the expectations around access into all primary care services. So yes, GP practices, but also optometry, pharmacy and dentistry. And then delayed transfers of care is the national commitment to improve the pathways of care for patients who no longer require to be in a hospital bed, but need something else to support them on their journey through the system. So this is what's one of the main areas that's different from the plan, and moving on from last year's focus. And as we then go forward, you'll see as we've maintained the life course approach. I won't repeat some of the messages that Nicola's gave when we reflected on last year, but we have done some work to review some of the metrics to really make sure that we have got timely information to make sure that we are changing the dial and making the improvements in these really important areas. Moving on then, the plan also sets out our commitments, recognising that service change and improvement to care rely on a number of factors being in place to support the improvements. The theme of quality and patient safety and patient experience running through, so sets out our commitments in this space. And partnership first, huge commitment articulated through the plan on how we work with our statutory partners, our third sector partners, as well as our other partners and local health boards. Using research and innovation and improvement to really explore the changes and improvements we can make to delivery of care. Working with industry partners and universities is a key theme of our plan this year as well. And the workforce and OD agenda, which I'll come on to talk about in the next few slides, as well as finance and digital and estates. The regional dimension has been touched on already. We work and have committed in our plan to work very closely with our local health board partners in the South East Wales region on a number of areas where we can see the benefits of combining our clinical expertise, our capacity, and working on joint pathways and joint capacity solutions. So our plan sets out our commitments around this in the areas of ophthalmology, so eye care, orthopaedics, and indeed diagnostics, and that's a key feature of our work in 23-24. But I did just want to acknowledge is then we have the framing of the life course, we have the ministerial priorities, expectations, and our own ambitions in terms of improvement. But it's important to acknowledge the context within which we are operating this year. In terms of the demand and capacity challenges, we are seeing a significant increase in demand into a number of our services. A few just called out here, but a growth in referrals into that cancer pathway of 20% compared to just before the pandemic. Similarly, I could have shared information on the growth into our mental health services for both adults and children. Huge demand increase for these services as we move out of the pandemic and sort of previous sort of activities resume. We still have, despite the improvements that Nicola set out, we still have excessive waits in areas for planned care. Some specialties more challenged than others. It's an absolute focus as we go forward, but we must recognise that whilst we see improvements, we recognise the challenges that this brings for patients and their families. And we are seeing challenges in the length of time patients are staying in our hospitals before they move on to either their next stages of care and support or to be discharged home. So real challenges we're facing in this area. Workforce I touched on previously. We are due to the demand and capacity imbalance I just outlined. It means we're spreading our workforce too thinly across a number of areas. And this then is driving a higher than we would like reliant staffing models. That impacts on well-being of our core staff, the sort of the sickness absence of our core staff. So a real challenge as we move forward this year in how we provide services in a way that we can robustly and sustainably resource from a workforce perspective. And those challenges aren't unique to us. Our colleagues in social care are experiencing very similar challenges. In terms of resources, due to post-COVID, the situation we all find ourselves in the public sector across the UK and Wales, post-COVID with inflation and some of the global factors. This plan this year, we are forecasting a deficit of over 100 million, which is a real challenge and a difficult position we find ourselves in based on the context of that demand I outlined and our ambition to provide services and continue to provide services across the whole of Gwent, which means that there's often conversations around how we can make sure we're using those resources efficiently, links with our workforce, and also we're maximising use in important infrastructure, theatres, etc. Sticking with our challenges around estate and infrastructure, we still, despite some of the really positive investments Nicola outlined, new developments, we still have a significant challenge around backlog maintenance of over 30 million in our current estate. And we are presented with some unique challenges in the health board with the presence of RAC, so reinforced autoclave aerated concrete in our site in Neville Hall, which we are required to respond to. And also we recognise whilst we've made huge improvements in digitising our workflows and our notes, we still have a significant way to go to really maximise the opportunities of digital. So it's against those challenges then that we come into what the priorities are for our plan for this year. So they reflect back to those life course areas, the ministerial priorities against where we find our risks. So the real priorities around improving the patient experience and timeliness of care in our urgent and emergency care system. The challenges that Nicola outlined previously remain with us, and so focused areas of work around that. We absolutely, and our clinical teams are behind us on this, we absolutely prioritise our most urgent patients when it comes to how we deploy our resource. So cancer patients taking priority with urgent patients and our longest waiting. And within that, a real focus on children and children's access to these services. the work we need to continue to build on and develop in place-based models of care. So looking at communities, not just the primary care services, but the wider community and other public sector and third sector services, and how we have a real focus this year on our mental health services, focus on the quality of those services, and some strategic developments, such as the specialist inpatient unit. To do this, we are going to retain our focus on the implementation of our quality strategy and a quality improvement lens on our services, developing and supporting our people through thinking about how we do recruitment and retention and how we attract local residents into our services, the financial improvements we have to make based on our context and really maximising those digital opportunities, but also recognising the need to have plans now for our remaining estate with a particular focus in Neville Hall. And whilst doing that this year, we are taking the opportunity to think about our longer term strategy, really working with partners and intent to come out to the communities to talk to communities about what the health service and the wider public sector in Gwent can look like going forward against those contexts. So at a high level, our priorities faced with the opportunities, and then the next slide just maps those. I won't go through this in detail. It just maps them to the where are we going to do this work, how are we organising ourselves internally, taking those priorities into specific programmes of work, some of which Nicola referred to will, in terms of the transformation programmes, they will continue and are continuing this year, and some of which are new that have been brought online to take forward these areas. And the last slide I just want to touch on is throughout this, we really remain committed to strengthen our relationship with public and our communities. It's been a significant priority for Nicola since she's come into post. And on this slide are just a number of examples for how we commit to doing this with colleagues this financial year. So through our already existing community engagement programme, our teams coming out into communities, into supermarkets, into local communities to talk and listen to experiences, the investment into our patient advice and liaison service to really strengthen that offer and that listening to patients when they are trying to access and get clarity. We're also committed to improving the information we share through our website in terms of waiting times, signposting patients to self-care and support whilst waiting, and also work we're doing around the digital inclusion agenda that will really help make sure that as we move forward with this commitment, we don't exclude anybody, and we as our reliance on digital to do this communication and engagement sort of increases. So it's really important we don't leave anybody behind. So I'll leave it there, if that's okay, and just as a high level sum where we're spending our efforts this year.
Thank you very much, Hannah.
And now it's your turn. Over to public questions and answers. Just if you could manage this on our behalf.
Thank you, Chair. Yes, we've already received 6 questions in total prior to the meeting, but as I've just put in the chat bar, if people would like to submit questions live while other questions are being answered, please do either raise your hand if you'd like to speak or type your question into the chat box. Thank you. So I'll move to the first question, and it's from Linda Joseph. And Linda has asked, can you outline what the Health Board is doing to address the financial pressures that have recently been announced? I believe our Director of Finance, Rob Holcomb, is going to answer this one. Over to you, Rob.
So there's a multitude of things that have been put in place over the last probably 12 months, reflecting that in 22 and 23 we were experienced financial challenges, and obviously that emerged in a deficit reported. So in terms of the approach, we've obviously got our governance arrangements that are long-standing, and we've strengthened those through additional focus at Finance Performance Committee, the board, and the executive committee to actually give visibility of where we are with our financial position, understand options and ideas for how we improve. We've got a rigorous profile of monthly work that is supported through the finance team with services to keep tabs and keep a record of opportunities and where savings programs and plans are developing and the stages of that. So that's the sort of governance piece. As an overall approach during the year, we determined a four-pronged approach. So I was looking at how we engage people and the workforce in terms of the agenda, try and get ownership and awareness of where we are, supporting through transformational change, looking at how we improve autonomy and accountability, and also monitoring and making sure we know where we are in terms of where our progress sits in the new year. So in terms of those elements, if you take a peopled approach, we've established a senior leadership forum, which is the executive team and all the senior divisional and corporate directors and senior staff in the organisation. That meets monthly, and there is a finance item on that, which gives updates, and we talk about options and ideas through there, which can be progressed. We've put extra training in place. There's training on the internet, as well as personal training, messaging through chief exec updates. And we've implemented a staff's savings suggestion box as well. So there's quite a lot in terms of that engagement piece that's been progressed and continues to be progressed as well. In terms of transformational change, we've got a series of priority groups looking at not just savings, but how we drive change. So in terms of how we improve our efficiency, how we improve our utilisation resources, there's a range of groups that are looking at it through that lens, as well as the budget holder lens as well. Because it's so our holding account and our schemes of delegation rely on budget holders living within their means and escalating up where that is proving challenging. So some of the transformational change, for example, is 6 goals programme, planned care programme, a discharge support project more recently, and looking at some of the value schemes, for example, like heart failure pathway redesign. In terms of autonomy and accountability, we've established a new budget setting mechanism for 23-24, which starts with a different approach in terms of how budgets are set. Again, it's part of that engagement and ownership to try and get that ground level ownership of driving change really and making best use of our resources. We've issued things like governance checklists for everybody to look at where they are in terms of self-assessments as well. In terms of enabling action, we've set up various groups, executive-led or otherwise, and they've been refreshed recently through the movement from the Efficiency Board to a Value and Sustainability Board. There's 6 themes around that being taken forward with more focus. Continuing healthcare, medicines management, non-pay, workforce, service reconfiguration and prevention. And those groups are utilising various resources through more recent ideas generation, looking at the savings proposals and plans we established as part of this financial year, looking at opportunities from benchmarking and other wider resources as well. So that's our, if you like, structural approach. In terms of what's emerged from this process, so in this financial year, we had a very ambitious savings target of £51 million. We're up to approximately £30 million that we're counting as what we describe as green rated schemes, which we expect to deliver. In addition to that, we've got more recently a process, as I say, where we've identified lots of ideas from the service. We've also had returns over 300 from our staff savings ideas. And some of the things we've actually put in place more recently are things like vacancy and scrutiny control panel for administrative roles, freeze on agency consultancy for administrative work, making sure that our IT equipment where we've been requested for investment, we haven't got alternatives available. that could be reallocated, freezes on purchasing office equipment and furniture, and again, just more sort of localised work around usage of photocopiers, switching lights off, things like that. And then in terms of responding to some of the staff ideas, and we've looked at the themes that have emerged of the 300 cases we had, and we've looked at how we've tended our facilities work with key trade contractors, promoted digital patient communication through a project there that should reduce waste and carbon footprint. Look at procurement work to identify opportunities for alternatives. Remote working policies being established, and again, that should help us with our premises footprint rationalisation. And particularly things that alluded to things like our logistics and use of taxis. So there's quite a lot that's actually emerged in terms of the process to date and progress to date. A lot of this information is provided in public reports through to our board and Finance Performance Committee if there's more detail required.
Okay, thank you, Rob. I've got another question to ask on behalf of Linda Joseph. Again, perhaps our Director of Planning and Performance, Hannah Evans, can answer this one. And the question is, there have been reports in the media about aerated concrete problems in public buildings. Can you please tell us what the Health Board is doing to address this and how this will affect services?
Yes, thank you for the question. So just to confirm, earlier this year, before the media reports about other public sector buildings, we, having been directed by Welsh Government, did a desktop survey of all of our estate to assess the presence or otherwise of RAC, so the aerated concrete issue. This identified that Neville Hall Hospital in Abergavenny does have RAC in it, following which we undertook with professional colleagues, so structural engineers, to do a detailed survey of the site, which identified that we do have RAC around, if you think of square meterage, it's around a quarter of the square meterage of the site has RAC in it. So mainly confined to the areas of single story. So it's not an insignificant issue. However, we absolutely give assurances that our focus in our approach since finding the presence of RAC has been on the safety of patients, staff and visitors. Following a very robust and thorough survey, we have risk assessed. Every single plank has been analysed by the structural engineers, and in response to that piece of work, we have in areas where the RAC is considered to be critical, we have put mitigations in place through the use of propping and planking. I'm pleased to report that we don't have that level of RAC in areas where we deliver patient care directly. So we haven't, unlike other health boards in a position with RAC in their facilities, we haven't had to relocate clinical services in that respect in terms of wards. We continue to work with our internal health and safety and fire experts, as well as the structural engineers, Welsh Government and the professional leads and shared services to run the rolling programme of checks on the areas of RAC. So we can provide, and we have today indeed provided assurance to the board about some of the actions. And we will continue, and we are continuing to work on what the service plan long term, because we cannot and will not continue to operate and deliver services where the props are indefinitely. It's not an indefinite solution. So we are working through what a service plan will look like for Neville Hall that addresses the issue of RAC and moves services away from the areas where RAC is present. So it's a multi-pronged approach, immediate focus on safety, mitigation of any risks, and secondly, focus on planning to move out of areas where there is RAC, regardless of the categorisation of it. So that is work that's in train now, and our commitment to work and communicate with staff, partners, our trade union partners, FLICE and others as those plans emerge.
Thank you, Hannah. The next question is from Teresa Harris, and Teresa has asked if she can ask this question herself. So Teresa, would you like to ask your question, please? Hello, Teresa. If you could possibly unmute yourself and ask the question, that would be great. Okay. Seems to having some technical difficulties, so I'll ask the question on Teresa's behalf. So Teresa's question is, I'm very concerned about the lack of opportunity for diabetic patients to voice their fears about the provision of healthcare within the health board. We no longer have patient reference group meetings and now cannot even attend meetings of the diabetes planning and delivery group. So where do we go? And Teresa also asked a question around the backlog of diabetes clinics and her concern about that as well. So perhaps our Executive Director of Therapies and Health Science, Peter Carr, could answer this one.
Thank you, and thank you, Terry, for the question. Really important subject. We, in terms of diabetes, we had a diabetes planning and delivery group, which was required of us as a health board from the National Delivery Plan for Diabetes. I'm really pleased to see that earlier in the year, the Welsh Government published the quality statement for diabetes, which has now replaced the National Delivery Plan for Diabetes, and we really welcome that in the Health Board, and we were even pleased to be involved in the development of that quality statement through the Diabetes Planning and Delivery Group, which I chaired. We had a conversation with Welsh Government about the future of Diabetes Planning and Delivery Group, as did all health boards, because all health boards had one. The advice and steer from Welsh Government was that we should step those down. One thing that they were really encouraged to do, and we as a health board wanted to do, was to make sure that the planning and in particular the delivery of health boards could sit with our divisions who are responsible for that, whether that be our medicine division or whether it be our family and therapy division and our primary care and community division, who all deliver diabetes services. And we really wanted to make the delivery of diabetes services business as usual and empower those services and directorates to deliver diabetes according to the quality statement that had been published. So it was with our government's endorsement that we stepped down the Diabetes Planning and Delivery Group. One thing though we made sure of, and it was probably our last conversation with the Diabetes Planning and Delivery Group, was about the important role of people living in our community with diabetes, that they can help us with the planning and delivery of diabetes, so we could hear their voice and we could respond to their service, to their needs through our services. We really enjoyed the benefit of a patient reference group for many years in Aneurin, Bevan, and we've had a few core members. Terry, you were one of them, and we understood that for various reasons those core members could no longer continue with the patient reference group, which we fully appreciate. One thing that I am really keen to do is to encourage other people in the community with experience of diabetes to come forward and work with us. In particular, I'm really interested to hear the voice of younger people with diabetes as well. I'm really interested in the transition from children's services to adult services, which is really important for diabetes. And as a result of some of the last conversations we had in the Diabetes Planning and Delivery Group, it enabled us to take that conversation forward with our patient-centred care team. And we continue to have that conversation about how we can employ the skills and the capacity within the patient-centred care team to bring the voice of people with diabetes into our service delivery. And that work is ongoing. I would welcome any help from anybody in our community who wants to be part of that. I'd really welcome you getting in touch with us about how we can involve you in that ongoing work. There won't be a planning and delivery group for diabetes, but there will be planning and delivery of diabetes services through our divisions and directorates. So we would be really keen to look anybody into that. Alongside that, I'm also leading the piece of work around transition and really keen to, which won't just benefit people with diabetes, but any young person transitioning into adult services. And we're looking to set up a transition board in the health board. And again, I would welcome anybody in our community who wants to be involved in that work to help us shape that and get it right. So yeah, so it's kind of really welcome. You know, when we had the diabetes planning and delivery group, our patient representatives were really helpful to us, and they never wasted an opportunity to raise concerns about the access to diabetes services, whether it be in primary care setting or whether it be in our hospitals. We recognise there are access issues, and you know, we are working on that. A lot of that is about recovering from the pandemic and getting our services back up to the level that we want them to be at. We're working actively with primary care colleagues to address the access. A lot of the feedback we had from patients over recent years was actually around communication, you know, and communication being an important part of that. And as Hannah said earlier, in terms of the INTP, I believe that digital plays a big part in that, in how we can enable people in our community with diabetes to have more control, more access to their care. I think that's where the answer lies, really. Then the final thing I want to say about diabetes is, as a health board, we're really clear that it's the longer term benefits from health promotion and ill health prevention where we can have the greatest impact on diabetes in the long term. And we've got to keep our view on that long term gain, really, in terms of health promotion. And that it's for that reason why Tracy, our Executive Director of Public Health, is for diabetes, so we can take that work forward as well and put that emphasis in that space. Terry might be able to release a mute button now and maybe want to come in and add any further comments.
Peter, if you can unmute your account on Teams, you will be able to speak.
If you are having problems, Terry, if you'd like to type in the chat bar, we can read what you have to say.
Can I also offer to Terry, you know, please get in touch with me outside the meeting. I'd happily follow up with Terry any further questions she has, and certainly happily respond to that outside the meeting if that works better.
Okay. Yeah. Thank you, Peter. Okay, we'll move to the next question, and it's from Councillor Marina Chakon-Dawson. And Marina has asked, Caerphilly County Borough Council are trying to do their part, but what will you be doing to address and assist with the issue of delayed transfer of care? So Executive Director of Nursing, Jennifer Winslade, is going to answer this one. Thank you, Jenny.
Thank you, James. As many people will know, we are working very closely with our local authority colleagues around discharge. We have established a discharge improvement board, which feeds both into the regional partnership board, but also the health board in terms of delivery of improvements in terms of delayed transfers of care. So we're working very closely with Caerphilly Borough Council, and we are working very closely with all of the local authorities within our health board area, including on how we might move to what is a trusted assessor model, which is how we work differently in terms of the assessment of a need of patients who we need to discharge to the home environment. But just a few things that we're doing at the moment. So we have an early supported discharge team called Hospital to Home. We're piloting that at the moment with local authority colleagues. That is about supporting people at home to have an earlier discharge in their pathway once they're medically fit, but where we support them and assess them within their home environment. It means that it's an environment where they feel comfortable, where they're very familiar with their surroundings, and therefore is a more realistic assessment of need. The early indications from the pilot are that that's been very successful, and we'll be looking to roll that out with local authority colleagues over the coming weeks and months. We're having weekly census days, so we're reviewing our data on a weekly basis with our local authority colleagues. So we've got a common understanding of where we are with the patients who are waiting to be cared for at home. And some of that will be how we work around some of the more complex discharges, but some of that is about how we move people home when their pathway is simpler. We've established a discharge hub at the Royal Gwent Hospital, working with Newport Local Authority, but also supported by Caerphilly Borough Council, really starting to look at how we manage the push back into the community of patients who are medically fit, with the appropriate support, of course, in the home. We've also got a pool model that we're working with in Neville Hall. That's with Monmouthshire Local Authority. And again, an integrated approach to discharge planning, working across our community services and our reablement teams. We also, as I say, have the integrated discharge board where we discuss all of these issues and work collectively and agree our collective priorities. The final thing to say is that we currently are taking a new approach to discharge. We're working very closely with our clinical teams and with our local authority colleagues on a rapid improvement approach to discharge. There's a pilot running today. We've been having updates through the meeting, and the progress looks to be incredibly pleasing in terms of the opportunity that gives us to have people cared for more closely to home. The one thing I will say is that it is in nobody's interest for patients to be discharged in a hospital setting. We know that there is an impact in terms of deconditioning, which is where patients become used to being cared for in that environment. And we know there are impacts on things like mobility with some significant evidence of things like muscle loss. We're working on a deconditioning metric so we can share that with our local authority colleagues, but also looking at how we understand how we work differently as a result of these patient safety team days. And as I say, first one today, looking to do more over the coming weeks and months.
Thank you, Jenny. Another question for you, if that's okay, from Councillor Kevin Etheridge. What processes, procedures, timescale and the cost in place for dealing with patients' queries in the Aneurin Bevan Health Board? And how are complaints monitored as they take a significant time to be dealt with?
So the first thing to say is that we accept and understand that there are delays that are occurring in our complaint system. Those are unacceptable, and we know that it has an impact on people. Nicola and I provide personal oversight of the process, and we have seen a change in the last 12 months in terms of, in particular, some of our very age delays that are over 12 months. And we're working back from that to move back to a position where we are compliant with Welsh Government targets, which is closure within 30 days. But we're also doing a number of other things. So we have approved a patient experience and involvement strategy. We have launching a PALS team in the coming weeks who will really focus on ensuring that rather than patients having to complain or their families, that we deal with those queries live and in the moment. And we're able to respond to people quite quickly, because we know hospital systems are really complex and sometimes people don't know where to go. And if the PALS team can't answer the query, they'll either follow that up very quickly or they'll signpost to the relevant clinical team to do that. As I say, Nicola and I sign off all complaints, so we're cited on the issues and the concerns within those. And we're currently working with our divisional colleagues to ensure that we have greater consistency in terms of the quality and the timeliness of response. So we monitor the performance very closely. We've got a plan to improve the quality and the outcomes, but we're also looking at making sure that those touch points into the health board are much more robust, so we can hopefully avoid a more formal complaint, which we know in most cases is not what people want to do.
Thank you, Jenny. Okay, moving to the last of our questions sent in before the meeting. We've had one come in live, which we'll ask after this one. But this is another question from Councillor Kevin Etheridge. And he's asked, please can you tell me the current costs of bank and agency nurses in the Aneurin Bevan Health Board, and what measures the board are taking to reduce costs and to recruit more staff? And if I can direct this question to Sarah Simmons, the Executive Director of Workforce and Organisational Development.
Thank you, James. So for the purpose of answering the question, we've included healthcare support workers in terms of the information as an important part of our nursing workforce. And just to give you some detail in terms of the current costs, so the costs this financial year to date. For bank and agency for healthcare support workers, there's a total of £9.5 million spent, and for registered nursing, £18.9 million spent to date. So as a health board, over the last 12 months, we have been implementing a programme of work to reduce our reliance on bank and agency. Primarily, we are focused on reducing agency in the first instance, and for our monthly average cost for this financial year, our healthcare support worker agency costs have been around £240,000 compared to being over £880,000 last financial year. And our registered nursing agency costs have been about 1.4 million per month, compared to last year, an average of 1.8 million per month. So there's some impact there in terms of the programmes of work developed. The measures that have been taken to achieve that fall into some key themes. The first theme is around our processes and policies and procedures, and making sure that we've got the right controls in place, that we are rostering and being as efficient as possible with our deployment of workforce. The second theme is around recruitment, and we have worked hard to recruit and enlarge our healthcare support worker substantive workforce, as well as recruiting overseas and locally for registered nursing. And of course, the third theme is a focus on retention, making sure that we support the staff that we currently have to stay with us and to develop with us. We have seen a slight increase in our bank costs for this financial year, but we will continue to work to support a reduction in those costs and ultimately to achieve our strategy, which is contained within our people plan, of increasing our offers, now permanent offers of employment. All of this work is importantly underpinned by a recently developed nursing workforce strategy, which is led by our Director of Nursing, and it has a range of measures contained within it around keeping the staff that we have and developing through career pathways, and widening access and creating more opportunities through nurse cadets, apprenticeships and flexible routes for training.
Okay, thank you, Sarah. Okay, just moving to the live question that's come in while the meeting has been ongoing. So this is from Nick Thomas, and Nick has asked, is the opening or the running of the new breast unit at YYF, Ysbyty likely to be affected by the 36.3 million revenue overspend mentioned earlier? Are that project's costs predicted to run over or stay within budget? And I believe our Chief Executive, Nicola Prigodic, is going to answer this one.
Yeah, thank you, and thank you for the question. So there's two elements to the breast unit business case. There's the capital funding that is required to build it, and that's been running for a number of years and is due for completion this financial year. And the capital funding is fully covered for us for this year, so there's no risk there. The 36.3 revenue is obviously continued into this year with an even bigger issue, but we have obviously planned for the breast unit business case with board approval. We continue to, in the light of increasing cancer demand, we've been just reviewing our service plans just to ensure that we've got the right staffing models, and our intention is that we will open that unit as planned. We continue to look, there's further development opportunities, and they will all be considered in line with our priorities, but cancer is considered to be one of our top priorities. So we don't anticipate any risk to the opening of the breast unit associated with the financial position.
Okay, thank you, Nicola. Okay, that concludes the questions that we've received. So I'll hand back over to you now. Thank you, Chair.
Thank you very much. And thank you all of you very much indeed for your helpful and interesting questions. If there are no further questions, it's my responsibility to thank you all for participating in our annual general meeting. I do hope you found it helpful and informative. And we look forward to seeing you again next year. We always welcome comments and questions from communities, individuals, and of course our partners. So please do not hesitate to send them in when you have any. And thank you very much. Thank you to the executive for their cogent replies, and we'll see you next year. Bye-bye.